Hello and welcome to Power Hour. We are the Pediatric Epilepsy Surgery Alliance, and we are an organization that supports families anywhere on the epilepsy surgery journey. My name is Audrey Bernick. I'm the Director of Patient and Family Advocacy, and I support families who, with any resources they might need. We support children all the way through adults who've had childhood epilepsy surgery. We have a number of other initiatives too. You can look on our website for more information. We were formerly the Brain Recovery Project. And today's presentation is sponsored by UCB. They're our new corporate sponsor. We're really excited to have some funding to make sure we can keep bringing these sessions to you. And in a second, you're going to meet our speaker today, Dr. Janelle Wagner. She is a neuropsychologist and has a wealth of experience working with at youth and adolescents with mental health issues, and is very connected in the epilepsy world as well. You can see her bio, which was shared with you when you signed up for this presentation. It'll also be on the YouTube channel when we share it later. So I'm going to stop share right now, and I'm going to hand the reins over to Dr. Wagner. Whenever you're ready to go.
All right. All right, can everybody see? Am I doing what I think I'm doing as far as sharing the right thing?
Looks good to me.
Okay, great. Well, thank you so much, Audrey. I'm very pleased to be here this morning. And I think that this space that you have for learning and sharing is really an important one. And I'm so delighted that Audrey reached out and asked me to come and talk with you a little bit today about behavioral health and wellness. So I'm going to be talking for a little while this morning, and then we'll certainly have time for questions. So please, if there's something that you have been wanting to ask but weren't sure about, like, there's no bad question. All questions are welcomed, and we're really here to be supportive to you and to share the information that I know from what I've been doing in my profession over the last 20 years. So with that, we will go ahead and get started. And I am just going to start a timer here so that I am aware of the time. All right, so I did want to start briefly with just making sure we are all on the same page. Behavioral health is a term that's getting used a lot more frequently now, but it's also something that people think maybe just has to do with behavior. What exactly is this? So I wanted to start with a slide that just covers what we mean by behavioral health. So this is the connection between a person's behaviors and the health and the well-being of the body and mind. So what we're talking about that encompasses behavioral health is a lot of things. It can include resilience and well-being, which might include quality of life. That's something you've probably all heard as well. Mental health, so anxiety, depression, disruptive behaviors, suicide, substance use, life stressors, and then health behaviors, which I'm going to talk a little bit more about today. So when we think about behavioral health, then we're thinking about all of these different things going into that connection between your behavior and your health and well-being of both your body and mind. So behavioral health care then involves support for those who experience mental health or substance use disorders, as well as their families and communities. And I want to highlight that because you all are here today as families and communities for youth with epilepsy. And so a lot of times this is also something that we're not paying good attention to. So really excited that the Surgery Alliance is creating this space for you. This might include mental health intervention, self-management intervention, which I will also mention today, as well as accessing community resources, both online and local. So I mentioned self-management. This is an idea that you may or may not have heard of, involving the things that we do to take care of ourselves, usually within the context of a chronic illness. So with epilepsy, when we talk about self-management, we're looking at what are the daily behaviors and actions that a youth and a family do to manage the seizures and the comorbidities associated with epilepsy. So that can include sleep. One of the things that we know about epilepsy is that sleep is very important. Some people have seizures during sleep. Some people, if you don't get enough sleep, that's a trigger for seizures. Nutrition is also a daily behavior. So we engage in eating, drinking, putting things into our body throughout the day. And again, we know there's a connection with that for some people with epilepsy who are using different diets to also help manage their seizures. Physical activity, so staying active and getting that cardiac as well as muscle strengthening. Social engagement is very important. And then caregiver involvement. And so I'm going to come back later in the presentation to talk a little bit more about this, but in the context of thinking about how we manage epilepsy, all of these things are involved. These are things that you do on a daily basis and can really promote health and well-being. Whereas on the flip side, if you have some unhealthy behaviors in any of these areas, they can also be associated with poor quality of life or even mental health symptoms. So in terms of prevalence rates for mental health in pediatric epilepsy, we know that about 25% of youth experience depression and 20 to 30% experience anxiety. Also, 30% are diagnosed with ADHD, and half of kids have learning disorders and or developmental delays. So when we look at the pediatric epilepsy population as a whole, 50% of youth with epilepsy have a cognitive or a mental health or a behavioral comorbidity. So it's not surprising given that seizures originate in the brain, as does learning, memory, and behavior. So many times when kids are experiencing seizures or even sometimes seizure freedom, they are also experiencing symptoms in these other areas as well. And then 15 to 27% of youth experience suicidal ideation. And these may or may not be kids who have scored higher on depressive symptoms. So suicide is something that we want to really pay attention to in youth with epilepsy as well, because we know that not all of these kids are acting on their suicidal ideation. But anytime we hear that a child has suicidal thoughts, that's definitely something that we as caregivers and health professionals want to act on and make sure that we can get youth the care that they need. So having said that, 50% of youth have comorbidities. What does this look like in terms of how these youth are getting mental health care? And some of you might not find this very surprising given to some of the struggles and challenges and barriers that you've had in accessing care. But a couple of studies have shown that when youth are identified as needing mental health care, only about 30% of those youth actually receive mental health care. So that's a small percent of the population of youth who are identified as needing mental health care who are actually able to get that care. Similarly, two studies looked at accessing referral care. So once kids were identified and referred out, so this would not have been in the same system as the epilepsy provider, but they were referred outside the system, only 20% actually accessed care. So again, there was a big disconnect between those kids who were identified as needing care and then the families at being able to access that care. And there were a variety of barriers that were identified here, including stigma, and then just not understanding or knowing what community resources were available outside of, in this case, an epilepsy center. So that gives a kind of an overall picture, and most of you are here today because your children have either had surgery or will be having surgery or are being worked up for surgery. So we're looking at what do we know about youth who are or have undergone surgery with respect to behavioral health. And I have to say, we don't have a whole lot of information in this area. We do have some studies that have included youth and adults, some studies that have included youth with all different types of surgeries. Some studies have tried to sort of figure out, is there an aspect of the epilepsy and seizures that would predict mental health outcomes for these youth? So what we do know is, and some of you may be familiar with Mary Lou Smith and her colleagues at Toronto Sick Children's in Canada, but they have looked most recently at outcomes in youth who have had surgery evaluations. And so what they found is that the lower cognitive abilities youth have, the lower the quality of life is 1 year later post-surgery. And they have also found that 1 year post-surgery, we do see an increase in physical activity, social activity, and behavior. So if you think back to what I just mentioned about health behaviors and the importance of social activity, caregiver involvement, physical activity, what we see is that surgery does provide improvements in those health behaviors for youth with epilepsy. So that's a really good thing, and that's a great outcome that we see post-surgery. As far as mental health outcomes, the few other studies looked at anxiety and depression, and what Dr. Smith and her colleagues found is that anxiety and depression did decrease over time, and that seizure freedom was associated with decreases in both anxiety and depression, but surgery was not associated with better outcomes. Okay, so this was actually a sample of youth that were evaluated for surgery, and then 1 year later, some of them had had surgery and some of them had not. And so what they found is that surgery was not associated with better outcomes. So what we tend to see from these studies is that at least within a year, and again, this study was not post-surgery 1 year, so there were varying times that kids had from surgery to when they were evaluated for anxiety and depression. It was just 1 year from the baseline or the first evaluation. We're not seeing improvements in anxiety and depression. And we're seeing that the higher your scores are pre-surgery, the higher they are at 6 and 12 months later as well. So surgery doesn't appear to be improving anxiety and depression for youth. What it does seem to improve is those health behaviors that I mentioned, and that as well as seizure freedom. One other thing is that older age and more seizure medicines pre-surgery predicted greater depression 1 year later as well. So again, we're seeing some risk factors for depression being older age, more seizure medicines, and then higher pre-surgery anxiety and depression scores, as well as continued seizures. So the important thing here seems to be that seizure freedom is related to lower anxiety and depression and not necessarily surgery. So I know that's kind of complicated, but take home is what we're seeing from the most recent data is that surgery is not improving anxiety and depression. So how about you? How about caregivers? And I know that we're here to talk about your kids today, but I come from a training and a model where very much so how caregivers are doing impacts how youth are doing. So I did want to put this in here as well. And I think it's great that Dr. Phillips and colleagues looked at this. So what do we see about depression and anxiety in caregivers? We see that, and this is the same sample that was assessed, and then they may or may not have had surgery over the next year, and then they were assessed again. And we see that depression and anxiety decreased over time for caregivers, and that seizure freedom, again, not whether or not the child had surgery, is what showed a meaningful improvement in depression 1 year later. as well as greater family resources. So again, that's not surprising that the more resources you have and the more support you have, the better you're doing 1 year later. So again, what seems to be important here is seizure freedom, right? So we're back to the whole, if we could just stop the seizures, whether it's surgery or another form of treatment, that seems to show the best mental health outcomes, both for caregivers as well as for youth. So I did want to share with you that there's a lot of really great work going on right now, and we haven't seen it impact clinical practice yet because it's still in the research stages. But the Pediatric Epilepsy Research Consortium now has a database of over 1,000 youth with epilepsy, ages 1 month all the way up to 21, from all of these different sites that I have on the map, and we're adding sites as we go. I was just in Fort Worth last week at the annual retreat for PERC, where we were discussing this database and how people are moving forward with that. And this is basically just there are providers who care about their kids with epilepsy, who have volunteered their time to enter the information from the clinical record for their kids who have undergone surgery evals. So what we're doing is in the beginning stages of looking at these 1,000 kids to see what can we learn from this information as far as what are the outcomes of these kids post-surgery. We do have mental health outcomes. So we have anxiety and depression and ADHD measures in there as well. So we can look in the next couple of years to see a lot of papers come out that will hopefully inform the way that we are providing care for our youth with epilepsy who are undergoing surgery evals, and be able to better tell you what you can expect post-surgery with your child. So that's a little bit of information about what we currently know. But what are you looking for? So as the caregiver, when I talk about anxiety, what are you looking for, and when is it important to be concerned? So I put this information up here because it's important to realize that anxiety and depression in epilepsy look just a little bit differently than they do in the general population. So I'm not going to go over necessarily what the classic anxiety symptoms are, but what we do typically see in general youth is irritability, anger outbursts, a lot of worrying, crying. What we see in youth with epilepsy is sometimes tied to the actual seizure event. So an aura that your child has, or physiological symptoms before a seizure, which can be hours, minutes, days before a seizure. Sometimes it actually is what lets you know that your child is going to have a seizure, can mimic anxiety. We also see worry, panic, and compulsion behaviors after a seizure. So again, what we see here is that seizure activity can be tied to and mimic anxiety symptoms. And so part of what's important for us to tease apart is the anxiety related to the actual seizure event, or is there additional anxiety beyond the seizure itself? And so we do certainly see classic symptoms. We see a lot of anxiety about seizures. So when am I going to have the next seizure? What happens if I wet myself during a seizure? What happens if someone sees it? And so because of that, there can be avoidance of social situations or being in public, and a lot of social anxiety between seizures related to when will I have the next one. And so this can make it difficult sometimes to identify and isolate anxiety versus seizure activity. So that's why it's important to, really kind of pay attention to these things. And I'll come back to this in a minute when I talk about keeping a journal or trying to track what you're seeing. All right. And then similarly for depression. So we do see some classic symptoms of depression, as in sadness and irritability. But what we see less common in kids with epilepsy is anhedonia, or this is the idea that you've lost interest in things that used to excite you or that you would find fun. We see less of that in kids with epilepsy. And what we see a lot of is low self-esteem and other cognitive aspects. So self-blame, just kind of being really down on oneself. And a lot of those things that involve the thoughts that you have related to depression. As I mentioned before, we see 25% that endorse suicidal ideation. And then we also here have to be careful about if there's a temporal relationship to the occurrence of seizures. So are we seeing these mood symptoms or these changes right before a seizure, right after a seizure, or are we seeing them in the days and weeks in between seizures, in which case we would be more likely to diagnose with depression and seizures and see this as separate than an aspect of the seizure event itself. The other thing to keep in mind is that a lot of the seizure medicines can cause side effects involving behavior changes, attention, mood changes, weight changes, feeling tired and fatigued, which these are all can be symptoms of depression as well. So one of the things that we really have to take in mind is, again, when was the seizure medicine started, or when was that dosing change given? And did we see these behaviors after that? Were they there before that? Have they gotten better or worse on the seizure medicine? So keeping careful records of seizure medicine and any changes to that is really important when we're looking at depression and anxiety in youth as well. And so then just thinking about some of the social aspects of epilepsy, you think about a diagnosis and how difficult that can be for a youth and for a family, and that feeling of that loss of independence. So all of a sudden, perhaps my parents are paying more attention to what I'm doing. I'm considering, am I doing sleepovers? If we are, we have to talk to people about that sleepover. What does this mean in terms of driving? And can I get my license? And, you know, what if I have to surrender my license if I have a seizure? You know, if I'm dating, do I want to tell the other person or not? So a lot of those psychosocial or just aspects of life, particularly in teens, as they start to desire more independence from caregivers, it can be really difficult to navigate that. And to know, like, how much supervision should I be giving versus how much do I need to back off and let my child sort of achieve these typical milestones in adolescence of establishing some independence. So suicide, I mentioned we see in 25% of youth with epilepsy. And so what is that? Just to kind of get us all on the same page. We can see this as a preoccupation with death and dying. We can see changes in sleep and eating. We can see taking excessive risks or sort of acting like I don't care anymore, because once someone has made a decision to take their life, many times they almost appear to be more well-adjusted and okay because they've made that decision and they feel like the hopelessness and everything that they have felt so strongly about, they have an option for. And so I always tell, you know, parents to really kind of pay attention to all of these different behaviors. And if you're seeing any changes in your youth, also increased substance use, things you might hear from your teen. I wish I could sleep forever. Nothing matters anymore. They'll be sorry when I'm gone, or it might be easier for them when I'm gone. And there has to be a better place here. And so many times people get very uncomfortable, understandably, about suicide because we're looking at something that is very important for us to discuss. But one thing I want to say is that sometimes people are under the impression that if you bring it up, then it will cause your teen to think about it more, or it's best not to bring it up because maybe they won't think about it. Well, here's the thing, they're thinking about it anyways. You know, if they are having suicidal thoughts, they're thinking about them anyways. But when you ask about it and give them that place to discuss it, it brings something that's very lonely to them out into the light, even just to the light of day, because someone else is hearing about it and is able to provide support for them. So asking about it and talking about it is a good thing, and we should be doing this instead of being afraid that if I bring it up, it will cause them to think about it more. And so one way you could bring it up is sometimes when people feel sad, they have thoughts of harming or killing themselves. Have you ever had such thoughts? And I know this sounds like tough, right? Who wants to use these words? Have you thought of killing yourself in talking to your youth? But I promise it's better to ask about it and to give them a space to talk about it than to, like I said, sort of not bring it up because we're afraid of what might happen or that we might cause them to think about it more. So how do you get help then? And that's a big question. And so I wish I had this answer today where I could tell you, call this number and you will get immediate help. What I can do is provide you with some information that will hopefully equip you to advocate for your youth. So there are a number of screening measures available now for depression and anxiety that don't cost anything to use. And they have been vetted in the research in the epilepsy population. This easy breezy that I have in the middle here is an anxiety measure that's been used in adults, but is currently being looked at in teenagers to make sure that it's still something that would be applicable in this population. But my point is there are screening measures that your providers can use that don't cost them anything, that are brief, that give you an idea of what might be going on with a youth. And these are not the entire measures here. It's just kind of a snapshot of what those items are, but they are brief. They take less than 5 minutes. What we know from a survey from the International League Against Epilepsy is that 50% of clinicians say that they screen and prescribe for comorbidities, and these are epilepsy providers. However, 50% of child neurologists rate their knowledge of comorbidities as poor or very poor. And this study was about 5 years ago. So I'm hoping that we're doing better now. And I can tell you that there's a lot of education going on at the American Epilepsy Society annual meeting, at the child neurology meeting, where we are training child neurologists, child epileptologists, how to screen for these things, including suicide. I know I've given a number of talks at ILAE as well as at American Epilepsy Society and other places where we are just trying to equip providers with, here's how you can do this in routine epilepsy care. Because we do know it's feasible. There have been a couple studies that have come out that have said, if you ask these questions during clinic, you can do it. It doesn't disrupt your clinic flow. It improves patient satisfaction with their visit. And it really does provide a comprehensive approach to epilepsy, because back to my earlier slide, if we're thinking about behavioral health as all encompassing, and we know that 50% of our youth with epilepsy experience a cognitive or mental health comorbidity, then these are things that should be part of a routine epilepsy visit. And so the first step would be talking to your teen about behavioral health and just starting the conversation. So you know what, I've noticed that, it seems like maybe you've been feeling anxious lately, or you've been feeling nervous lately. I mean, it's important to use whatever language or vocabulary you've heard your youth use before, and say, using I statements. So again, if you are saying, I've noticed this, that comes across as much less demanding to a teen than you're acting like this or you're doing this. So use I statements to just tell them what you've noticed and that you are concerned, and help them understand the connection between their seizures, their behavior, and their emotions. Even if it's just very briefly what I mentioned today about the fact that there is a connection, and validate for them that this is normal, and half of kids are in the same boat you are if you're experiencing these symptoms. And then encouraging them to seek help. So when is it important to seek help? If you notice that your teen is constantly worrying about what's going on, is avoiding friends, school, other activities, is really struggling to complete tasks. Now, again, this isn't to say, of course, if there are memory struggles or other executive function or cognitive struggles, then completing tasks may be hard for your youth. And so that would be a different discussion as far as an academic evaluation and what kinds of educational supports that they might need. But if you notice that, if that's already been taken care of, or if those are not concerns that you have, but you see that they're still really struggling to complete things, or they're fighting and arguing with you on most days, and they're really just irritable and angry, and it seems like everything you do is wrong. Now, I do have to say that, to put this in context a little bit, if you have a teenager, sometimes they're just angry and irritable for no particular reason that you can understand, and sometimes that they can understand either. So again, we're kind of navigating like what's typical teen behavior, and one day here or there, yes, that's the case. But if you're seeing this most days, so the importance here is the most days. Feeling like everyone is out to get them, and then having suicidal thoughts or plans. So how would you bring this up during a visit? It's important to prepare ahead of time. So what questions do you have? Of course, you're probably very familiar with the list of medications, the family history, but this is with respect to mental health. So is there a family history of mental health disorders? Also discuss with your child who wants to bring up these concerns. Is this something they want to do with your assistance? Is this something they would feel more comfortable with you doing? You can also practice. So how would you say this? Because sometimes when people get to a visit, it's very overwhelming and the clinics move fast and you feel like maybe they don't have time to listen to you, or maybe you're intimidated by bringing this up. So it's important to know kind of who is going to bring it up and practice. Also keeping a journal, and I'll come back to this in a minute, and then letting the provider know at the beginning of the visit that you have concerns and you want to make sure that you set aside time to talk about those today. Because if you wait until the end, they might be halfway out the door and on to the next patient. And you want to make sure that they know at the beginning of the visit that you want to include this in your time. And then be honest and ask questions. So in terms of a journal, this is something that can be very helpful. And you may have already done a seizure journal or a seizure diary, but you can do this for mental health symptoms as well. So how many times a day is this happening versus the severity? How much? So in other words, if you, on a scale of 1 to 10, how anxious are you? 1 would be pretty low, 10 would be extremely anxious. So the youth can even keep track of this. And are there specific things that are happening right before I feel anxious, or right before I feel really sad? And then you can write down, do you notice this is particular times of the day? Is this particular situations that are going on? Is there a peer, interaction that's related to this? Is it homework related? And just kind of what is happening. But this can be very helpful, especially as I mentioned before, if you're having any seizure medicine changes, right? Because we know that sometimes after kids have surgery, then they will be weaned off their medicine, and some kids stay on their medication, but those doses are changed, or even the medicine is changed. And so do you notice those differences in behavior with the medicine changes? And if you're keeping track of this, it's much easier to provide that information to be able to answer those questions. So here's a few ways that you might bring this up. The top one is, how would you as a caregiver bring it up versus maybe a way that you could coach your youth in how they might want to bring this up with a provider. And so let's say that you do bring it up with the provider and you are referred. What kind of treatment is available? So what is behavioral health treatment? What exactly does that look like? And so most behavioral health treatment for youth involves a couple of things. And cognitive behavioral therapy is the most common, which targets cognitions or emotions, your thoughts that you have, as well as your behaviors. And then the physical sensation. So do you get increased heart rate? Do you feel like that pit in the bottom of your stomach that just makes you feel awful? And connecting all of those things together, because if we're able to change some of our behaviors and think about things differently, then that can really impact how we feel, which starts that cycle then of impacting behavior and thoughts moving forward. So things like exposure and relaxation are used for anxiety. And then cognitive reprocessing. So changing the way that you think about things. And then for depression, we often use problem solving. So, teaching youth how to solve a problem and then go back and evaluate, did I make a good choice here? Did I get a good outcome? Also cognitive reprocessing, so changing the way that you think about things, those healthy habits that I mentioned earlier and increasing activities that they enjoy, as well as working on how you communicate with others and what your relationship quality is like. We have very few studies specific to youth with epilepsy, and none that I'm aware of as far as post-surgery interventions. But we do have a lot of good data in the general youth population to suggest that these things that I just mentioned can be very beneficial to decreasing anxiety and depressive symptoms. So just briefly, when I mentioned cognitive reprocessing, what is she talking about? Again, it's changing the way that you're thinking about something. And so one of the ways that we can introduce this in therapy or treatment for youth is the idea that when you make changes to your behavior, that can affect outcomes for you, right? So when you have control over something, then if you make changes to your behavior, it affects the outcome. So back to this idea of self-management and health behaviors, right? So let's say if you're not getting enough sleep, you're eating a lot of junk food, if you're not getting much physical activity and you're doing a lot of gaming and just not getting out and moving, maybe you're pretty isolated, there's not a lot of social engagement, these are things that you can change. So in your daily life, you could take action to get good sleep hygiene, get on a regular sleep schedule, remove distractions, that kind of thing. And so this is one way that we can make changes in our behavior that impact our outcomes for mental health. And so these are just some examples of ways that might do that. And for time's sake, I'm going to click through these. But the second type of coping is secondary coping. And this is when you can't change a situation. So in this case, you can't change that you have epilepsy. So we have to change the way that you think about it, right? And this is where that reprocessing comes in and that taking another perspective. So thinking about, is there anything good that can come from having seizures or going through this process that your youth has and that your family has? Are there ways that it has made you stronger? Does it give you insight into other people? What are you doing with that? And yes, we can't change that you have epilepsy, but also that doesn't define who you are. So really looking at changing the way that you're thinking about a situation. So we talk about in treatment, this idea of, okay, we're going to make some changes over the behaviors that you have control over that can impact outcomes for you. And then we're going to change the way that you think about some things to have perhaps a different outlook, because that in these situations, when you can't change the fact that you have epilepsy, is really going to empower you to perhaps see what good comes from this. How does this make you stronger? This is easier said than done, which is why we typically start with changing behaviors, because you can see an improvement in that pretty quickly. But it does take a little bit longer to change the way that we think about things and to change our perspectives. So I've just shared with you what my professional journey has been and the things that I know from my job. And I just realized that I've been talking way too long. So I apologize for that, but I do get very excited when I talk about this because I really want to empower parents So I'll just briefly say that I came into the epilepsy field because my brother, Aaron, who's 3 years younger than me, was diagnosed with epilepsy as a child at the age of 10. And then he went on to have left temporal surgery where they removed his amygdala and hippocampus in his left hemisphere. And so, and then he did not have any more seizures after that. So my family has walked this journey as well. And that is why I am here in this space advocating for youth and for families. And then I do want to just end with some resources, which I think maybe I won't go through each of these for the sake of time, because I want to make sure we have time for questions, but I can certainly discuss these in the context of questions as well. So Audrey, I know you told me to talk for 30 minutes and I talked for 37, so I apologize.
It happens. It's a important topic. It was a lot of great information. I really appreciate it. There's a couple questions that came up in the chat, and then I have a couple questions as well, but I'll start with a parent question, which I thought was a good one. Are there any ways to determine if fatigue is depression related or just a normal post-surgery outcome?
That's a great question. So I think it depends on the timing, right? So it can take 3 to 4 months for kids with epilepsy. I mean, for kids who've had surgery to really regain strength. And, you know, having surgery on the brain takes so much energy. And so you may see that your child is eating a lot more, is needing to sleep a lot more. I mean, this is just the body's restorative way of recovering from something really big that has happened. So we typically wouldn't want to look at that until I would think 4 to 6 months post surgery to really be able to rule out that it was related to the surgery versus.
Yeah, the parent who asked the question, their child is more than 10 years out from surgery. So we're talking like a longer, not immediate post-surgical recovery or even in that first year or two, but further out. How would you determine that? I see Monica raising her hand, so maybe she can unmute and chime in or put something in the chat. But if you want to answer, Janelle, like when you're looking at it further out, sorry, Dr. Wagner, further out from surgery, because a lot of our, especially with the bigger surgeries, they do experience, chronic fatigue, chronic headaches, these kinds of things. So either Janelle or Monica, whoever wants to answer it.
Yeah. So Monica, I don't know, you've got your hand up.
Well, I was just going to say that in our patient registry, so we do have a registry where it's a patient-powered registry by parent proxy, and some of the parents here might be familiar with it. And one of the questions we do ask is whether the children have fatigue postoperatively. And I would say, without going back in to check, that about 20% of them do experience what I would characterize as a chronic fatigue. And I think there's a paper out there out of the Cleveland team that talks about chronic fatigue post-op. I'd have to check. The one thing that I worry about with a lot of these kids is whether the fatigue is actually very slow and subtle onset of hydrocephalus, which we know it occurs at a relatively high rate in our kids, between 20 and 30%. And I'm also looking at this with the backdrop that for my son, hydrocephalus has been worse than the 3 hemispheric procedures he's had. Yeah. But it just makes me wonder out loud if, with the kids that are experiencing this long-term chronic fatigue, whether they're having disrupted regulation of cerebrospinal fluid flow that's not rising to the level of enlarged ventricles, or maybe you haven't even checked the ventricles in years because they're not doing the regular hydrocephalus stuff like vomiting or, unable to wake them and things like that. Just something to think about.
Mm-hmm. Yeah. And I know that Dr. Wagner, I don't know how familiar you are with it, but we do see in the post-hemispherectomy TPO, like the big hemispheric procedures with the onset of hydrocephalus, it's often missed. because they're looking at the brain in a different way. They're looking at the symptoms in a different way. And then parents really have to push, and then they figure out that that's what it is. That's, obviously that's I think one of the things that's so complex about this is that each child is so uniquely complex in their constellation of factors. And how do you tease out what's, I actually had a school team ask me once when I did a school training, I need to know what's behavior and what's medical. This is a child who had a hemispherectomy, and I said, it's all medical, right?
Yep.
Ultimately, at the end of the day. Do you have anything to add there on that question or comment?
No, I mean, I think just a lot of the things that were brought up, as far as many times it is kind of trying to figure out this puzzle and teasing apart what's what. Sometimes we're not able to do that either. So I would certainly want to, speak with the medical team about that if you have concerns and wanting them to pursue looking at that from their end of things, to be able to rule that out. Sometimes when we're looking at this too, what we're doing is we're ruling out some things, and then if we still see these symptoms, then we're saying, okay, it is related to mental health. And that's not to downplay mental health, but to say that there are so many other things related that, if let's say it is fatigue and it is hydrocephalus, that's a very different treatment than if it's fatigue related to depression, right?
Yeah.
So we want to make sure our treatments would be very different. We want to make sure what's causing it.
Yeah. And I think even to the parents' question, when you get into the adult world, like you talked about how few pediatric neurologists understand the comorbidities. When you get to the adult world, the adult neurologists and neurosurgeons don't understand pediatric epilepsy surgery, if at all. And so then understanding that, the impacts of that, and then the comorbidities, I would think there would be even less of a knowledge base there. I might be wrong, but that's my understanding. So that's kind of an added challenge, I think, once our kids reach adulthood and they age out of their pediatric providers, because at least in the pediatrics, there tends to be a little bit more of a comprehensive view. There's another question here, which I think is a good one. And I don't know if you can touch on hormones and menstruation and how that impacts mood and all of that, but I'll read the question. The question was, her daughter has had no treated seizures since her hemispherectomy just before age 5. And she also had a grid resection before age 4. She struggles with anxiety and mood swings. She was born early at 24 weeks, has CP and developmental delays. However, she's very verbal with a huge vocabulary. We've also been dealing with CPP. I don't know what that is, since age 5.5. And
Central
now,
precocious puberty.
okay, so precocious puberty. And so now with her having her menstrual cycle, she's almost 11. She changes into the ugly child within a matter of a half a second. This is very taxing. As her primary caregiver, I'd love to hear your thoughts and recommendations. And then also still deals with fatigue, and she's 6 years out from surgery. She naps most days.
Sure. Yes. So hormones, they do throw some challenges into this for sure. And, we do see in girls specifically, so the rates of depression in the general population in girls and boys is equal until you introduce hormones into the picture. And then we do see higher rates of depression in females. And part of that thinking is due to the hormonal changes, and certainly premenstrual symptoms and a lot of the issues that girls can deal with menstrual cycles can create all kinds of issues for people with mood and behavior. So one thing that I would suggest, if you're noticing this specifically around menstrual cycle, is to speak with the pediatrician, and or if she's seeing someone in gynecology. I know that sometimes they will see younger kids who are experiencing puberty if there's a lot of other issues going on as well, because they might want to talk to you from their perspective about a way to better manage the hormonal changes that are associated with that. So that, I know, I would suggest that. And then I would also just say, if you know that there's a particular time, let's say the cycle is regular, and so then a couple things that you can do is, not that we want to tiptoe around it, but if we know that it's coming and we know that, okay, this week is going to be particularly challenging, then what can we do to set up that week? So are there any stressors we can take out of that week? Are there ways that we can schedule those rest times during that week because we know that she really needs those. So it's sort of planning for when you know that that is going to be more difficult, could be helpful too. And then, I mean, I think there's probably a lot of just, little things here and there in terms of ways that you can respond when you see that behavior. But unfortunately, it's probably outside the scope of being able to talk about it on here just in terms of time. But that's where having a behavioral health provider could be so helpful for you, because that person would be checking in with you on a regular basis and helping you with, here's some things you can try and then come back and let's talk about if it worked or not. What did you notice from here? And again, just tracking that behavior. So if you're introducing new things, if you're doing new things, are you also tracking the daily mood or daily behavior, because you'd want to know, like, is it getting better or not? And it's really hard, I will say, retrospectively, because as a caregiver, if you've had a really hard week, you're most likely going to remember that week as, I'm not going to say worse than it was, but you're going to pick out all the things that were really hard about it. Whereas if you're keeping track prospectively or moving forward, you have that information that you're not being asked to recall when you're in a super stressed out state yourself. And so our reporting is a little bit more accurate when we're taking it over time, as opposed to thinking back retrospectively.
Monica wanted to share something with us, so I'm going to let her jump in.
Yeah, this is something we talked about this summer at the family conference, was this overlap of endocrine issues after surgery. We had this abstract we presented at the Endocrine Society meeting, and here's just some early data from our registry that shows that there's a 1 in 10 kids is diagnosed with some sort of endocrine issue after surgery. 1 in 20 has an early puberty, which is much bigger than the general population, which is like 1 in 5,000. But when you look at the kids that have hydrocephalus after hemispheric surgery, 1 in 3 of them has an endocrine issue. Most of those are puberty. Sorry, of course, my dogs are starting to wrestle as I'm on here.
Can't hear the dogs, you're good.
Yeah. So for Dawn, my concern again is I would be concerned about whether there's some sort of undiagnosed high pressure that caused this central puberty and is now early puberty, and is now causing the fatigue during the day.
Yeah.
We talked to the neurosurgeon about some imaging.
Mm-hmm. Yeah. Yeah, it's kind of crazy, because in our community, we have families where we'll talk about the hydrocephalus, and recently this happened where I was supporting a family and the parent was asking their surgical team, and there were behavior issues, lack of progress, and some other behavioral issues, just flatlining, no speaking, no progress for a year. And they finally pushed and pushed and pushed and got a sedated MRI and CT scan, and she had really bad hydrocephalus. And they just, so as parents, I think sometimes it's really hard for us to stand up to our doctors. I mean, you talked about the kids learning how to be self-advocates. We also have to remind ourselves that until they can do that, we have to do that for them. And that can be really hard, because sometimes we feel uninformed, right? Like, it's like, what do I know? I'm not a doctor. Who am I to tell a doctor that they should do X, Y, or Z? And even in the behavioral health realm, I think it gets even more complex. You and I spoke before the presentation today about the battle between the neurologist and the psychiatrist. So if you have a child who has epilepsy and is maybe on epilepsy medication, and then they also have a mental health issue, and you want to treat that mental health issue, sometimes psychiatrists are like, I'm not seeing a kid who's on epilepsy meds. And then the neurologist doesn't know how to address the mental health issues and doesn't want to prescribe psychiatric medication. So sometimes we're caught in this catch-22. I do have one more question before we wrap. I don't see any others in the chat right now. My question was about, what do we do for the children who don't have the ability to maybe participate in therapy or other strategies, like they're cognitively not able to participate in like a typical cognitive behavioral therapy or journaling or some of the things that you've suggested, but it's clear that they have kind of anxiety and depressive symptoms. Maybe they have intellectual disability or speech impairment or something that causes them to not be able to participate fully. Do you have any recommendations for those kids? Because I think that's sort of like those kids fall through the cracks a lot, and we know, we see it, we can see it in the child, but then what are the supports? And, you know, it's hard to even tease out, I guess, but I'm just wondering if you have any recommendations for families whose kids may fall into that spectrum.
Yes, and this is a really great point or question. So yes, I mean, there are things that we can do with kids that have lower cognitive abilities. I mean, certainly when we think about anxiety, depression, there are a lot of behavioral aspects too. And so we would focus treatment a lot more on those and less on the cognitive processing part of that.
Mm-hmm.
So there are a lot of great, I mean, I mentioned relaxation. So there are small things that you can do, like the stress release balls can be tactile for kids too, who really need that like pressure or ability to do that. There are soothing things that we can use, whether it's, you know, just different tools that provide sorry, I'm having word finding problems, kinesthetic experience for kids that can help with anxiety. And then what we would do in the case of depression is really focus on the, you know, getting involved in things that you enjoy and scheduling those types of events. So trying to lift the mood through behavioral aspects and not focusing so much on the cognitive. And in kids with intellectual disabilities, there is less of the self-blame and, you know, negative criticism that you have in a child that has typical cognitive functioning, because that's the way the brain is working too. So in a sense, we would be treating what we would be seeing in those kids, which would be more behavioral manifestations of anxiety and depression. So there's absolutely, through that behavioral component, changing some things about the child's behavior, the way the child's day, the way people respond to the child, and then providing the child with those coping skills, whether it's through something like a stress ball, teaching relaxation, finding out what really, and this point was brought up earlier, what really makes a child you know, excited or moved, and each child's going to be different. So it's really kind of finding what's rewarding to that particular child or what's soothing to that particular child.
Mm-hmm. Well, this was really wonderful. I really appreciate you taking the time to join us today. We're really just honored to have you, and I learned a lot. Hopefully everyone else did too. And just thank you so much. And I hope we can have you back again in the future.
Yes.
Excellent.
And I will just quickly say, sorry, I didn't mention anything about the resources. So just a couple things. There are some resources that, and I will share my slides so that Audrey can give those out. There are a couple things for caregivers that I have on there, but there are some resources through Epilepsy Foundation, through Society of Pediatric Psychology has a parent well-being support program as well. And just, so please take a look at those links and see whether there might be something that you didn't know about that you might be able to access that would be helpful in that sense. Obviously, I wish I could just send a behavioral health psychologist or psychiatrist to everyone's home who needs it, because we know that that's really, we have a shortage there, but I promise you we are working on it in terms of educating professionals so that we can start to see a change in routine epilepsy care so that this is included in it.
Well, that's wonderful. I'm really excited about what you're doing. I do feel like there's a sea change happening kind of in this issue, and you know, these issues that we've been discussing today. So I'm really excited to see, and you're part of it. You're part of making this all happen. So thank you for what you're doing.
Absolutely. Thank you so much for having me today.
All right. Thank you. Take care, everyone.
Bye.